This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2016, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is Infection Prevention, Translating Science into Practice. Cheryl Hoerr is a registered respiratory therapist, certified pulmonary function technologist, fellow of the AARC, and the Director of Respiratory Services at Phelps County Regional Medical Center in Rolla, Missouri. Ms. Hoerr discloses that she is a clinical consultant for South Medic. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis.
Today I'm here to talk to you about infection prevention. Specifically, we're going to talk about the chain of infection. You know, it's important for therapists to understand how an infection happens and where they can intervene to prevent the transmission of infectious microbes from patient to patient or from caregiver to patient. We're going to identify some infectious diseases relevant to the practice of respiratory care and discuss different regulations regarding the environment of infection prevention. We've also had some questions from our therapists about reprocessing equipment, and we're going to talk about those standards for respiratory equipment. And finally, we're going to talk about the different isolation levels to keep us safe and prevent the transmission of infection. You know, infection prevention used to involve passive monitoring. The goal of the infection care expert was to make sure that we were minimizing the effect of infections in the hospital, but truly, hospital-acquired infections were considered kind of a normal piece of a hospital stay. The specialists would create policies to prevent transmission, educate healthcare providers on those policies, and then monitor how successful we were at preventing infection. It was basically a passive process, and what we found was that knowledge really didn't change practice. We continued to have infections in our hospitals, and we really didn't make much of an impact on reducing those infections. Today, it's not infection control, it's infection prevention. We want to make sure that we do not cause an infection that wasn't present when that patient came to see us. It's our responsibility to protect that patient, to make sure that they receive excellent care, and to make sure that as a consequence of the care they receive in our hospital, they don't go away with something worse than when they came in. The primary goal remains to prevent infections and make sure that our infection prevention experts continually explore emerging research and bring to us any techniques and tools that have been shown to reduce infections or hopefully prevent infections. Our infection control specialists partner with other regulatory bodies, including the FDA, the Joint Commission, and the Centers for Medicare and Medicaid to develop evidence-based practice standards to ensure that our healthcare facilities are up to date and doing all they can to prevent those infections from happening. Through all these efforts, it's commonplace for leaders in the field to work with policymakers at the state and regional level and testify to implement new regulations and reduce infections in our hospitals. You know, all of this evidence-based practice and all of the research and all of the involvement by these organizations really helps us develop transparency. We know that our patients are now looking for that level of transparency And they want to know what our infection rates in our hospital are. They want to know that when they come or when a loved one comes, they're going to be safe, and that we are doing all we can as healthcare providers to eliminate the chances of an infection. The goal of infection prevention is therefore to protect the patient, to protect the healthcare worker and other people inside the hospital environment, and doing those things with a low cost. You know, in addition to preventing infection, we do want to be efficient and effective, and that means working to reduce costs. As I said today, consumers see the value of a low infection rate. They're aware of the amount of time that they will spend in a healthcare facility and expect, as they should, that no harm is going to come their way as a result of the poor care they might receive. So let's talk a little bit about the chain of infection. This might be a concept that you learned back in school. It really hasn't changed, but it has been refined and simplified so that it's easier for healthcare providers to understand where their actions can affect the transmission of infectious agents, where healthcare providers can intervene and break the chain so that an infection doesn't happen in the first place. There are 3 elements needed for the transmission of infection. You need a source for your microorganism, you need a susceptible host, and you need a means of transmission for that microorganism. Prevention of healthcare-associated infection means that we can intervene at any step along the chain of infection and essentially cause a break in that chain. How do we understand this chain and get to the source of our interventions? There are human sources of microorganisms. A healthcare worker can come into the hospital with an incubating infection. Patients themselves have an overgrowth of microorganisms, and when their immune system is weakened, they could have an infection for themselves, and that could be transmitted to another patient through a careless healthcare worker. Visitors and anyone in the incubation period of an infectious disease, those who already have a disease and come to the hospital. You know, healthcare workers do come to work sick, and we should probably prevent that from happening because they can transmit their illness to a patient. There are chronic carriers of disease who are well themselves but can incidentally transmit an infectious agent to a patient. All of those sources can come in contact with your weakened patient and cause a disease. There are even inanimate objects, such as respiratory equipment, that if not decontaminated properly, can cause disease. So we have to be very conscious of the level of decontamination, the level of infection, the number of patients the number of people coming into contact with our patients, all in an effort to limit exposure to disease and potential transmission of an infectious microorganism. As I said, subclinical cases and carriers present risks to patients with weakened immune systems. We all know that healthcare workers who have been in an acute care facility environment for some time are colonized with MRSA. Usually that's not a problem for a healthy person, but someone with a weakened immune system could develop a full-blown case of that illness. So we have to make sure that we recognize those sources and put barriers in place to prevent transmission of infection. As I said previously, our hospital culture sometimes encourages sick workers to come to work. We're chronically short-staffed, we need the help, we feel guilty that we're not there, that our coworkers are going to be picking up the slack if we're not there to work, and that encourages us to come to work when we're sick. We really shouldn't, and there should be more stringent standards to prevent and support healthcare workers to prevent them from coming to work and support them when they stay home. And of course, the chronic hand washing issue. Even with all the evidence out there, we know that healthcare workers still are not good about washing their hands. About 60% of us do not consistently wash our hands. We don't follow those guidelines and inadvertently transmit those pathogens from patient to patient. We know that following standard precautions, following the isolation guidelines that have been put into place, and engaging in proper hand washing is essential to breaking this chain of infection. So once you have a pathogen in place, whether it's a microorganism on a piece of dirty equipment or carried from one patient to another on a healthcare worker's hands, we have a situation where the chain of infection is going strong. There are 5 main routes of transmission of bacteria. We've talked about human transmission, but mostly we have contact, droplet, airborne, common vehicle, and vector-borne. The first 3 routes are the most critical and the ones that we most guard against in an acute care situation. And they're the most important transmission sources of nosocomial infection. Contact transmission is direct, surface to surface, and indirect from contaminated objects. As I said, surface to surface is hands to a patient, indirect, equipment to a patient. Droplet transmission is when infectious droplets are generated during coughing, sneezing, talking, and through procedures such as bronchoscopy and suctioning that generate aerosolized particles with infectious agents in them. Transmission occurs when the droplets are propelled through the environment, a short distance usually, and deposited on those mucous membranes of a susceptible host in the mouth, in the nasal passages, or conjunctiva. Droplet transmission shouldn't be confused with airborne transmission, and that's easy to do, because droplets don't remain suspended in the air, and special handling and ventilation is not required. So let's talk a little bit about airborne transmission. Airborne transmission happens when particles containing bacteria or airborne droplet nuclei, small particles, less than 5 millimeters, of evaporated droplets containing microorganisms are suspended in the air for longer durations of time. Microorganisms transmitted in this manner can be inhaled by a susceptible host. Smallpox and Mycobacterium tuberculosis are a few examples of bacteria that are spread by airborne transmission. Most of us are very familiar with tuberculosis and are very comfortable with the precautions that we put in place to prevent that. We do have to remain aware that many of the procedures we perform and the technology we actually use to prevent illness and treat illness can provide easy access for infectious agents to travel from patient to patient. This is a compromise of the first line of defense caused by surgical operations and anesthesia, and indwelling catheters can also render patients more susceptible to infection. Anytime we put a device and create an artificial opening in a host, in a patient, is a direct line that an infectious agent can use to infect that host. So let's talk about the host for a little bit. That's the next step in that chain of infection. The host, if healthy, usually doesn't develop an infection. But factors can make or break infectivity. The older a patient is, or the younger a patient is, can affect how immune they are to any kind of pathogen. If they have comorbid conditions, which many of our patients do, they can also be more susceptible to an infectious agent. if they're receiving certain treatments that affect the ability of their immune system to fight off infectious agents, such as our patients receiving chemotherapy or post-transplant. Then we have to have a high level of suspicion if they start displaying any signs of an infection. And finally, if they're also receiving radiation therapy, that can also reduce their ability to fight off infection. And we see these patients every day on every unit of our hospital. It is up to us to keep a high level of awareness, know our patient's history, and understand how we could inadvertently infect them and what we need to do to prevent that infection from happening. Because even if we have all of our protections in place, even if the patient has a strong immune system, there still is a chance of infection. Illness, in and of itself, is stressful. And we have evidence to show that stress can negatively impact the immune system. So just by being hospitalized, a patient can be more susceptible to infection. I know that's something that I don't really think about often. I think a patient's hospitalized, we're doing all we can to help them get well, things are going well, and then bang, they come up with a fever, they come up with signs and symptoms of infection. Unfortunately, I think that's something we need to take more into consideration. Being sick is stressful. Who knew? So infections happen. And there are really a lot of nasty infections around. We've heard a lot in the press about some of those nasty infections over the summer. Many of our patients, once they come to us, have already been exposed. And it's a sad fact that our patients come to us for care and end up exposed to other infectious agents that they didn't have when they arrived. I'm going to concentrate on healthcare-acquired infections for the majority of this talk, but I did want to briefly discuss what's been happening with other infections outside of the healthcare environment. There are community-acquired infections and healthcare-acquired infections. It seems as if there's been an increasing number of outbreaks in the community in the past several years. And that's likely to continue, which means that a large portion of a therapist's normal workload will include caring for patients who have some sort of infection. It's our professional responsibility to make sure that we have the skills and the knowledge to provide the appropriate clinical care when we're asked to do so. Cindy Monroe, who is a nurse and the editor-in-chief for the American Journal of Critical Care, says that outbreaks reinforce the importance of critical care knowledge, skills, and teamwork in uncertain situations. Infectious diseases have always posed risks for healthcare workers, and it's our duty to use all our knowledge and skills to protect ourselves, our patients, and the public, and to prepare for future challenges. That makes sense. And it's really a call to us to step up our game. It's not the same old anymore. We have to consider other things going on with our patients outside of what we are concentrating on at that point in time when we're administering a respiratory treatment or therapy. As you can see on the slide, there are a lot of nasty infections, bacterial infections, viral infections, and they're all around us. And these things are becoming more prevalent as people move around the globe much easier. These pathogens hitch rides on airplanes, on boats, on people, and they show up in your community when they haven't been there before. One of the big ones we heard about recently was chikungunya. That's a mosquito-borne, a vector-borne illness that causes fever and severe joint pain. It emerged in the Americas for the first time in 2013. And before that, it was basically rarely seen in the United States. In 2014, after chikungunya was identified in the Caribbean, there was a significant increase in the number of American travelers infected. People like to go to the Caribbean, take a nice relaxing vacation, and unbeknownst to them, they bring a small traveler back with them. So we saw an increasing number of cases of chikungunya in the United States, and 75% of the sources of those infections had traveled from the Caribbean. While preparing this talk, I learned about a listeriosis outbreak last year in 10 different states that were tied to caramel apples that were distributed around Halloween. 28 people were infected, 26 hospitalized, and at least 4 people died from listeriosis. Not something we normally hear about. There were 3 other outbreaks in 2014 tied to other products, soy and cheese products. And we're all aware of the recent Legionnaires outbreaks in various cities throughout the United States, specifically in California and Illinois. At this point, there have been multiple deaths and hospitalizations. We heard that initially they thought in New York they had contained the source of the outbreak, some contaminated air conditioning units. They were disinfected and put back into service. Problem solved, right? Unfortunately, a few weeks later, there was a repeat outbreak in the same area, the same equipment. So obviously, either the decontamination wasn't done as effectively as it should have been, or, and there is a concern, is that there is some resistance developing in these pathogens. This summer, we also heard about a larger outbreak of human plague. Now, every year across the United States, there are a few outbreaks of plague, a few cases. But this year, there were quite a few traced back to Yellowstone. 11 cases and 3 deaths were associated with those outbreaks. Now, there is uncertainty why so many different outbreaks of unique diseases are occurring. But we can be assured that this kind of trend is going to continue. As I said, people are more mobile, they're more active, they're more interactive, and when that happens, we share pathogens. And unfortunately, if you are susceptible to that, you will end up sick, your patients will end up sick. I've included a slide here about the first quarter information on influenza and pneumonia. As respiratory therapists, you know that this is a seasonal illness that we deal with, a seasonal pathogen that peaks in the early winter months and kind of slacks off throughout the summer. As we can see from this graph, it's starting to tick up. So we can see that the flu season is starting early this year. There have already been cases seen in emergency rooms across the United States. On average, about 20% of the population get the flu every year. Annually, more than 250,000 people are hospitalized. That's a lot of patients. And between 3,000 and 49,000 die from the flu, depending on the severity of that year's strain. Hopefully this year, with the quadrivalent vaccine, we'll have a milder season and not so many people taken ill. When we do have a larger outbreak, it leads to economic loss through lost productivity, lost days at work, and that can be more than $10 billion in direct medical expenses. More than $16 billion of that is lost wages and earnings. We also continue to hear our experts discuss a pandemic flu outbreak possibility. Novel strains of the influenza virus that humans really have little to no immunity are emerging 3 to 4 times a century. Since 2012, global health officials have been tracking a new strain of the flu, H7N9, first reported in China. It's led to 175 deaths globally so far, primarily in Eastern Asia as of October 2014. They've been able to contain it to Eastern Asia, but imagine what would happen if it started traveling and if it started being able to be transmitted from human being to human being. That's a scary thought. So according to the CDC, those are the most common pathogens that cause health-acquired infections. They're listed here: Staph aureus, E. coli, Pseudomonas, strep, C. diff. Those are not strange words to anyone who works in acute care. We see those all the time. Our patients are colonized, have chronic infections from these pathogens, and we work hard to keep those pathogens isolated to those patients and not transmit them to others. But healthcare-associated infections aren't just limited to bacteria. Fungi, such as Candida albicans and Aspergillus, as well as viruses such as RSV and influenza, have also been implicated in a number of hospital-acquired infections. Hospital-acquired infections are caused by breaches of infection control, breaches in that chain of infection, or non-breaches in the chain of infection. The chain of infection is allowed to continue, and the unclean and unsterile environmental surfaces, ill hospital staff, and infected visitors transmit that infection. Now, prevention of hospital-associated infection includes following proper hand hygiene: good hand hygiene on the part of hospital staff, good personal hygiene, proper disinfectant and sterilization of equipment, not just respiratory equipment, all equipment, and providing a clean sanitary environment throughout the facility. Today's risks are often mitigated by a better understanding of the pathogenesis and the routes of transmission of these pathogens. We also have a very wide availability of personal protective equipment, and everybody is familiar with standard precautions. When we follow that knowledge, when we have that knowledge and the skills to implement those preventions, those precautions, we can break that chain of infection. Preventive efforts and supportive care requiring high levels of infrastructure are rare, but do occur. And when that happens, we need to pay attention. As I said, hand washing is not often easy to accomplish. Even with all of the gels and hand antiseptics distributed throughout a patient care unit, there are many times when healthcare workers do not follow standard precautions. They get in a rush, they're busy, they forget, and they don't wash their hands. They don't disinfect between patients. And that's critical to preventing an infection. It's critical to interrupting that chain of infection. Keeping our patients safe requires both individual effort, and make no mistake, it is an effort, individual effort and exceptional teamwork. If you see one of your healthcare coworkers coming out of a room not wringing their hands with antiseptic, not drying their hands, challenge them. We need to look out for our patients. We need to advocate for our patients and keep them safe. And if that means going up to a coworker, approaching a physician, talking to a family member to say, did you remember to wash your hands? We owe it to our patients to do that. We have to be exceptional at adhering to the established infection control practices that have been put in place. It's the only way we really can keep our patients safe. So let's go back to that list I just showed you. The results of a recent study were just published and outline something interesting, although it's probably not too surprising. They did a survey with 183 hospitals. Out of 11,282 patients, 452 of them had one or more healthcare-associated infection. Device-associated infections, such as catheter-associated infections, catheter-associated urinary tract infections, and ventilator-associated pneumonia. which have traditionally been the focus of programs to prevent healthcare-associated infections, accounted for almost 26% of those infections. So I said earlier, devices really need special attention because they can transmit a lot of bad infectious agents. The estimate is that there are more than 500,000 patients with over 700,000 healthcare-associated infections in U.S. acute care hospitals, and that was in 2011. Do you think it's improved at all to this day? I don't know. Of note, 39% of pneumonias were associated with mechanical ventilation. So that's something that we as respiratory therapists need to take ownership of. Yes, we have improved. Our rates of ventilator-associated pneumonia have decreased, but even one infection is too much. Imagine if that were your loved one and they were put on a ventilator to get over an acute illness and then developed ventilator-associated pneumonia. I don't know about you, but I'd be pretty upset if that happened because that is a completely preventable infection, and it's on us to make sure that that infection doesn't happen. Because when a patient comes up with a healthcare-associated infection, their risk of death increases. There was another study, the results of which were published in the American Journal of Infection Control in January of 2015, that said when elderly patients developed a healthcare-acquired infection, even if they got discharged from the intensive care unit, their risk of death within 5 years increased by 57%. That's sad. If an elderly patient had VAP, their risk of death increased by 77% in 5 years. The ongoing cost of running an infection prevention program is fairly expensive. In the ICU, one study stated that it costs about $145,000 for prevention efforts. That's staff costs, documentation, communication costs. Seems like a lot of money, especially in this day and age when our reimbursement is being reduced and we're all trying to cut corners on expenses wherever we can. But this probably isn't the area to cut corners, because despite the fact that this particular study quoted $145,000 in costs, they also reported that their efforts reduced ICU costs by $175,000 for central line associated bloodstream infections and $163,000 for VAP. So they were well worth their money, more than a double increase on your investment. The healthcare environment is a dangerous environment, and with the emphasis on reducing costs, there is a risk that the wrong programs will be targeted. It does cost a lot in direct medical costs to care for a healthcare-associated infection. As you can see on the slide, there's a range, 35 to 45 billion when those infections emerge, which includes the cost of the technology, the cost of the staffing, the cost of the space to care for patients, etc. Those are direct costs. But there are indirect costs that aren't often included, such as the cost of the lost wages of that patient, their diminished productivity, which is days out of work or school, their short-term and long-term morbidity, their mortality, income lost by family members who have to be at the hospital to be with that patient, to care for them once they come home, lost leisure time, not something we often consider in the cost of an infection. And then any time that's spent by that patient, family members, traveling back and forth. Sometimes that's quite expensive since families are so spread out these days. They might just not live in the same town. So there's travel costs associated. Intangible costs include psychological costs like pain and suffering. Things you really can't put a number to, but you know they're there. Pain and suffering. Change in social functioning and coping with activities of daily living. All those are intangible costs of healthcare-associated infection. CMS reported that there was a 17% decline in healthcare-associated conditions from 2010 to 2013, but this was far short of the 40% goal that they originally set. But they said, well, we are doing a better job. We prevented 50,000 deaths. We avoided 1.3 million adverse effects, and we saved 12 billion. So we are making progress. We are developing that evidence and adhering to it, but we need to make sure that we're doing better. I've included a graph on a publication entitled Outbreaks, Preventing Americans from Infectious Disease. You can find that on the web. And it rated states in terms of their contributions and efforts towards preventing outbreaks of infectious disease and healthcare infections. And as I said, they have declined in recent years, but this publication says that around 1 of every 25 people who are hospitalized each year still contracts a healthcare-associated infection. And only 16 states perform better than the National Standardized Infection Ratio for central line-associated bloodstream infections. And only 10 states reduced the number of central line-associated bloodstream infections between 2011 and 2012. I think we need to do better. So let's talk a little bit about infection prevention challenges. I've already talked a little bit about the decreasing reimbursement. When your hospital reports a higher than average healthcare associated infection rate, you get an increased penalty as far as reimbursement. And it's not just for that patient, it's for all of your Medicare patients. So it could be a significant hit for the hospital. It also will bring increased scrutiny, not only from the press, which will be sure to put it on the front page, but also from your patient population. I know I wouldn't want to be hospitalized at a hospital that has a higher than normal infection rate. I'm probably going to start looking around and see if there's anybody closer that has a better rate. We do have increasing drug costs, which can potentially make it harder to treat these healthcare-associated infections. If the hospital has to pay out more for good drugs to fight increasingly resistant strains of pathogens, we're going to have to cut back somewhere else. That's going to hurt. But despite these challenges, work is proceeding on effective methods to reduce the cost of healthcare-associated infections. We've already talked about reducing the incidence. It's happening. Reducing morbidity. It's happening. Shortening hospital stays. Reducing costs of treating infections. Reducing the cost of preventative measures, such as vaccines. Encouraging not only the public, but healthcare workers to get vaccines. And most especially using evidence-based practice to maximize our interventions, maximize our infection control efforts. Despite all of those improvements, we do have some challenges. There are increasingly resistant organisms, the so-called superbugs. Antibiotic resistance isn't new, but it's definitely an emerging global concern. MRSA was discovered in 1981. Its incidence is 25.1 per 100,000 patients. And I said earlier, most healthcare workers are already colonized with MRSA. It's found on the skin and nose in 1 of 3 healthy people, basically symptomless if you're healthy. It's widespread in hospitals and resistant to most antibiotics. When fatal, it's often due to the septicemia it causes, and it's most likely caused by patients treated in multiple hospitals. You know, those patients who go from hospital for one condition and then get admitted to another hospital for another condition. That assists in the transmission of that pathogen. There are 3 types of bacteria showing resistance: Klebsiella pneumonia, E. coli, and Staph aureus. Superbugs and antibiotic resistance mean that more than 2 million Americans fall sick of antibiotic-resistant bacteria every year, and more than 23,000 die from those infections. Antibiotic resistance is estimated to cost the country more than $20 billion extra in healthcare costs and $35 billion in lost productivity. That's a lot of money, especially when we're all struggling to make healthcare more affordable. There is some good news. You know, we've all heard very scary stories about carbapenem-resistant Enterobacter, but the overall incidence is not as high as MRSA. In fact, the overall incidence is relatively low, only 2.9 cases per 100,000 people. Risk factors, not unexpected: prior hospitalization and indwelling devices. So that's better than MRSA, but hopefully it will stay that way and we won't have to deal with more cases. So that's kind of the environment of healthcare-associated infections. We've got some fixes in place, but we need to continue to change. We need to continue our efforts, despite the fact that change is hard. There really isn't any option anymore. We can't survive by doing the same things we've always done and hoping things will be different. These bacteria and viruses are getting stronger, so our preventive efforts need to be stronger and more effective. Therapists need to proactively evaluate what we've done in the past, what's working, what we're doing now, what can we get better at, what will fit into the new model of quality and cost avoidance. And remember, if we don't avoid those costs, it will decrease our hospital margin, and if we don't have a margin, we will not have a hospital mission. We will cease to exist. So we have to use evidence-based practice to reduce healthcare-associated infections and improve the care we're providing to our patients. So let's talk a little bit about the regulatory environment. Hospital-acquired infections are not inevitable. Unfortunately, they are common, getting less so, but still common. But the public is coming to understand that these infections are kind of an indication of the quality of care that's provided at an organization. The higher the infection rate, the lower the quality. And because of the increasing efforts at transparency, that information is out there in the public and easily obtainable. Healthcare-associated infections are a cause of major harm and an economic burden to our hospitals. And to that end, to increasing transparency, we are now required to report mandatorily our infection rates. There's been a push for a more automated and streamlined process by the government so that we can increase transparency, that they can gather data and calculate rates of infection more easily. And studies have shown that when a system is automated, just the mere fact of monitoring it and that more data is inputted into the system, your infection rates will drop. There was a study done and they showed that infection rates dropped threefold because the hospital had the ability to follow the patient throughout their hospital stay, You know, patients move to different units throughout the hospital, and sometimes we lose them and that data is disjointed. But if we can follow them and follow that transmission of infection, we have better data, more reliable data, a more real-time tracking of how we treated that healthcare associated infection and how that patient responded. It's estimated that only 20 to 30% of organizations these days have that type of an automated tracking system. So that's one thing that hospitals need to do better at. And in 2013, all but a handful of states had requirements for mandatory reporting of their data. And as those requirements become more stringent, I believe many organizations will move towards those automated reporting systems. So hopefully we will all be able to track patients in real time and intervene quickly when we see an infection developing. The AHRQ, the Agency for Healthcare Research and Quality, says that it may take as long as 1 or 2 decades for original research to be put into routine clinical practice. 1 or 2 decades, that's a lifetime. We have to get better at organizing our data, at developing the evidence and the best practices, and then integrating that into our daily practices at each organization. We have to move faster. Today, as we're exploring the emerging research and identifying new and better ways of reducing risk of adverse infections and complications, we need to partner with agencies who are already on the cutting edge and have data that could be integrated into our practice. And I'm talking the FDA, the EPA, the CDC. We need to be out looking and partnering with these organizations and taking their efforts and not reinventing the wheel. That's how we get that data into our practice quickly and are able to integrate that evidence into our practice. The goal of infection prevention is to protect the patient, protect the healthcare worker, and others inside the healthcare environment, and to do those things with a low economic burden to hospitals. We said that earlier. Evidence-based practice will do that. Today's consumer expects low infection rates. They're aware of the amount of time they may spend in the hospital, and they expect that we are intervening and preventing infections so that they can get home to their loved ones quickly. So our goal is to prevent infections in our patients and prevent the spread of infection any way we can. Now, we've had some therapists contact the AARC, put it out in our listservs. What do I do? What do I do if an Ebola patient comes to my hospital? What do I do if I see SARS? What do I do when MERS shows up? Well, the problem with those is they are still relatively rare in the United States. And always, as always, if that happens, you need to protect yourself first. There are unusual circumstances, but you're always going to protect yourself first. It's like putting your oxygen mask on if the plane is going down. Put your oxygen mask first and then your companion. And any advanced training that is needed to treat these patients will be offered to you by your organization if you are identified as one of the providers that will be taking care of that patient. It really doesn't make a whole lot of sense to go out and train a bunch of people now for something that might not happen or might not happen in 10 years. You're probably going to forget everything you learned if you're not using it. So that advanced training will be provided in a just-in-time environment. And it will be an organized, specific response because your organization might be designated as a center to take care of these patients, or it might not. You might see a patient through your emergency room that will immediately get shipped to one of the designated care centers, and you'll never even see that patient as a therapist. It will be your emergency room staff. So yes, there are extreme circumstances. Yes, these situations are scary, but there are procedures in place that will be brought to bear if something happens and you are taking care of that patient. But once again, you're always going to be using those standard precautions, using the equipment that's available to you every day on the floors in your routine care to protect yourself. That's of primary importance. So keep the panic low and protect yourself, and ask for the training as needed. And as I said, that equipment, that protective equipment, is usually available to you wherever you turn around. It's in the nursing units, it's in your department, and you need to remember that this basic standard precaution applies to all patients. It's your gloves, it's your gown, it's your mask if necessary. Universal precautions and body substance isolation. First line of defense is hand hygiene, using your gloves. Maybe you need a gown if it's a contact isolation. Maybe you don't. If it's going to be splashing, wear the gown. Same thing with a mask. If you have airborne or droplet precautions, you want to use a mask. If there's going to be splashing, you want to use a mask. Eye protection, same thing. If you're drawing a blood gas, making sure that you have a protected needle, making sure that you dispose of that needle properly and you don't get stuck. This is very standard practice in medicine, and we're still seeing needle sticks. We're still seeing people, as I said, I've already belabored the point, not washing their hands. So these concepts are not new. They were introduced in the 80s, 1985 to 88. They've been adjusted as our knowledge has grown, and started out as universal precautions. Now it's standard precautions, which is a combination of the universal precautions and the body substance isolation. So that should not be a foreign concept to any respiratory therapist. And as I previously talked about, the application depends upon the extent of risk and exposure you're anticipating. Always anticipate worst case. You'll never be sorry that you wore a mask when that patient coughs and you end up with contaminated secretions all over you. The person who's sorry is the one who didn't think they needed the gown. Source control measures, covering the nose, mouth when you sneeze, using a tissue. That's something that's relatively new, and that campaign is gaining in publication, in exposure, because that's kind of a new addition onto standard precautions. So we have all the standard precautions. We always want to make sure that we're covering our nose and mouth with the tissue, and we're asking anyone else who's coughing to cover their mouth with their hand, with the tissue, wash their hands afterwards. We also want to make sure that we're safely handling our contaminated equipment, making sure that we decontaminate it preliminarily in the patient's room as necessary, then moving it out and doing a more thorough decontam at a secondary site. If a piece of equipment is something that will be used between patients, you obviously want to take great pains to make sure that you're decontaminating that equipment thoroughly. We're going to talk a little bit about which pieces of equipment have really popped up on Joint Commission's radar in a little bit. But respiratory is notorious for reusing equipment that is labeled as disposable. So if you are reusing equipment, I would really encourage you to consider following the manufacturer's recommendation and making it single patient use if that's what the manufacturer has specified. You will never regret following those standards, and you might just be caught causing a healthcare associated infection if you don't. So consider following those standards and not reusing equipment whenever possible. I know in my department we've gone to mostly disposable equipment. Many years ago we used to have an equipment cleaner. We were able to reuse equipment and reduce costs, but when you consider the costs, and we've talked about all those direct costs, the indirect costs, and the intangible costs of a healthcare associated infection, is it really worth it? I don't think so. I think you can make the case to your hospital administration, and you can probably involve your infection control team to support you to say, we need to stop reusing these things that are really single patient use. So let's talk about the basics of standard precautions. The elements are listed here on this slide. You have to educate patients, staff, visitors on what your expectations are. And there are a lot of good signage products that you can place at your main entrances to say, if you're sick, please consider not visiting. If you have to visit, put a mask on, cover your mouth. When you cough, use a tissue, dispose of the tissue quickly and properly, and wash your hands if you're coughing. So those are all kind of common sense things that aren't so common anymore. I did read something that said physical proximity has a lot to do with the increased risk of transmission of infection via droplet route. So if you're in a waiting room, or if you're overseeing a waiting room and one of your patients is coughing, you might want to separate them from the rest of the waiting room population and get them at least 3 feet away from anyone else, just in case. That you don't want that transmission of an infectious agent to start before you've even seen that patient. We've talked over and over about the effectiveness of good hygiene practices, so I won't belabor the point. Anything that will be effective in decreasing the risk of transmission should be uppermost in our minds. And as we know, you can't always tell when someone's sick. So if there's any suspicion at all, you want to act proactively. I know if I were asked to wear a mask, if somebody thought I was sounding a little congested or possibly running a fever, could I please wear a mask? It's for the best of our patients. I don't see a whole lot of pushback. Yes, you might get somebody who's not happy, but if you couch it in terms that this is best for our ill patients and we'd appreciate your cooperation, most of them will cooperate. Especially patients who really haven't been taught that cough etiquette. If they're coughing and not using their hand to cover their mouth or not using a tissue, just a quick hint to say, hey, here's a tissue. They appreciate that. I've done that before, if you do it in the right way, obviously. So wear your mask, do your hand hygiene, and keep them safe, keep yourself safe by using the right protective barriers. And if you have an infection, maybe you call in sick to work that day. Another effective way to prevent the transmission of infection is isolation precautions. Obviously used to help stop the spread of infection from one person to another. We have several tiers. What we have in place is a tiered system based on transmission. So we want to employ these precautions when we know the microorganism and disease, and we select the best isolation based on how we know that organism is transmitted from patient to patient. So contact isolation, we've already talked a little bit about that, but it's used for infections, diseases, or germs that are spread by touching the patient or touching items in the room. MRSA, VRE, E. coli, RSV. Healthcare workers should wear a gown and gloves when you're in that patient's room. You should remove the gown and gloves before you leave the room, not out in the hall. You want to keep those pathogens in that patient's room isolated. You want to clean your hands by hand washing or using hand sanitizer after you remove the gloves. And as always, of course, you've already done that before you enter the room. And make sure that visitors check with the nursing station before they're entering the room, because they're going to have to gown and glove too. You don't want them coming out of that room and then spreading infectious agents as they're leaving the hospital. Droplet precautions are used for diseases or germs that are spread in tiny droplets caused by coughing and sneezing, pneumonia, influenza, whooping cough, which seems to be gaining in prevalence, bacterial meningitis. You always wear a mask when in the room. Discard the mask in the trash after leaving the room. Protect yourself. You don't want to take that mask off while you're still in the room. You'll inhale the droplets. Clean your hands. How many times can I say it? Wash your hands with soap and water or hand sanitizer when you enter the room and leave the room. And then finally, airborne precautions used for diseases that very small germs are spread through the air from one person to another. Tuberculosis, measles, chickenpox, that type of thing. You need to make sure your patient is placed in a negative pressure room, right? You want all their pathogens staying in their room, being evacuated from the room through a filter and outside the building. The door should always be tightly closed. I know you feel it isolates the patient may not like it, but it's for their protection, for your protection, and for the protection of the rest of the patient population. Wear an N95 mask. You stay safe. You don't want to inhale any of those pathogens. Wash your hands before and after you leave, before you enter the room and after you leave it. Ensure that the patient is wearing an N95 or a surgical mask when they leave the room. And any visitors to that room also have to wear a mask. And speaking of masks, I did want to make sure that as in droplet precautions, you leave the mask on until you're outside, and then you dispose of that mask outside of the room. Keep yourself safe. So I think we've talked a lot about isolation, washing your hands, protecting yourself. Let's transition a little bit and talk about some of the issues that have received increased scrutiny lately, such as respiratory equipment and reprocessing. There have been some items in the news lately that therapists need to pay attention to regarding reprocessing of respiratory equipment. And I will tell you that the Joint Commission and CMS are looking at these things, because when we do not reprocess quickly or appropriately between patients, we end up in trouble, and we could cause a healthcare associated infection. The one item of equipment that has received a lot of press are bronchoscopes. Actually, the issue started off with endoscopes and the fact that they traced infections in patients back to a contaminated bronchoscope, an endoscope that hadn't been decontaminated effectively. And we heard on the AARC Connect that, hey, heads up, if they're looking at endoscopes, chances are bronchoscopes are soon to follow, and lo and behold, they did. So what the FDA has been looking at is, are departments following the manufacturer's standards for decontamination? And those standards require proper training, adequate time to disinfect the equipment, and an infection monitoring system, basically culturing that equipment to make sure that you are not cross-contaminating your patients. There's plenty of information out on AARC Connect and out on the web in general if you're more interested in delving into that in depth. Another high priority item on Joint Commission's radar is how you reprocess your heated wire temperature probes. Why is that important? Because that temperature probe is actually inserted into the ventilator circuit and comes in contact with contaminated patient secretions. So you can't just wipe it down. The problem is when you look at the manufacturer's recommendations, the manufacturer says wiping down is fine. The issue is that you have to make sure that the products they recommend are the products you're using. So if the manufacturer recommends wiping down with product X and you're wiping down with product Y, Joint Commission will cite you. Be specific. Follow exactly the manufacturer's recommendations. So if you don't have product X, you're going to have to decontaminate your heated wire temperature probes in a different manner. And they will check. Laryngoscopes and laryngoscope blades are another issue that Joint Commission has been paying particular attention to. Many people have gone to disposable laryngoscope blades just because it's easy. You don't have to worry about all those nooks and crannies when you're reprocessing them, and they're also individually packaged, so you don't have to worry about them becoming dusty and contaminated in an airway roll or in a crash cart. Joint Commission is specifically looking for that. So the best solution is a disposable blade. As far as handles are concerned, they're considered semi-critical pieces of equipment. They could be contaminated, but Joint Commission says it's okay to wipe them down with the hospital-improved disinfectant. You can do a high-level disinfection through your central sterile processing if you'd like, but wiping them down and then putting them in a sealed bag, like a baggie, where that cleanliness can be maintained, once again, in the airway roll. You don't want that handle to get dusty and dirty while it's waiting to be used. And finally, disinfection of nebulizers continues to be an ongoing issue because there's been some confusion around how exactly you decontaminate them. And there was verbiage out several years ago saying you have to decontaminate between each treatment, that you have to wipe them down, or else use a new nebulizer. And the AARC worked with CMS state surveyors to clarify this. And CMS has new language out there and says that nebulizers, jet nebulizers, are single patient use. They're cleaned per patient policy by rinsing with sterile water and air dried between treatments on the same patient. Pretty straightforward. If you're using a mesh nebulizer, those usually remain in the vent circuit and they're not cleaned between treatments, and you change them out as the manufacturer has suggested. And then with the new nebulizer drug combinations, you make sure you're cleaning them according to manufacturer's specifications. So pretty straightforward. There may be further clarifications of that. There's still some confusion, so we are working with that, with the AARC on clarifying that language. So stay tuned, but right now, as long as you're rinsing them and air drying them, you're fine. You shouldn't be cited. So what's the upshot of all of this? In order to reduce healthcare-associated pneumonias, your level of awareness needs to be at a higher level than it's been before. And you need to be protecting yourself. You need to be keeping yourself healthy, making sure you get your flu vaccine, your immunizations are kept up to date, you're following standard precautions, wearing your gown, gloves, mask, goggles in any situation that may require that equipment. You're following safety precautions put in place to make sure that you don't get stuck with a contaminated sharp. And you're following respiratory etiquette, covering your mouth when you cough, using a tissue and disposing of it appropriately before washing your hands, and you're encouraging others to do it. your coworkers, visitors, patients, that type of thing. If you are protecting yourself, you will remain healthy, hopefully. You have a better chance of remaining healthy anyway. And you will protect your patients in that way. It's one of the best things you can do to break that chain of infection, because you're the one that's seeing that patient most often. You're the one that's going into that patient's room and could potentially introduce a pathogen that that patient can't fight off. You have the skills to break that chain of infection. Prevention, that's the key. Prevent the infection before it ever starts. Avoid the costs. Avoid the pain and suffering. Keep that patient healthy. Save costs. And we're all good. In the end, the respiratory therapist has the power to break the chain of infection. We have the skills to do it. And prevention is the key. There are many evidence-based practices out there that we utilize on a daily basis to prevent infection. Be a champion of non-invasive ventilation. If your patient isn't intubated, they can't get ventilator-associated pneumonia. So prevent that tube from going down. If your patient is intubated, do what you can to minimize sedation. We know that the less sedation a patient has, the easier it is to wean them from that ventilator, the easier it is to extubate them and get them off the vent. Early mobilization is another way you can keep your patient's strength up, keep their immune system stronger, help them get off the ventilator faster, get out of the ICU. Encourage early mobilization of your patients. We also know that secretions that pool above the cuff of an endotracheal tube are a prime source of infection. So use endotracheal tubes with subglottic suctioning if that's available to you. Elevate the head of the bed 30 to 45 degrees. Keep the patient's head up, keep the secretions from pooling. Change the vent circuits only if they're visibly contaminated, and follow the established infection control practices in your organization. Be a champion for doing more. Advocate for your patients and keep them safe. Thanks.